Welcome everyone to the session on paediatric deformity. Apologies for the slightly late start. Neither Adrian nor I knew that we were chairing this session. I'm not sure who was supposed to be chairing this session, but welcome. And as soon as we find out who the first speaker is, we will welcome them to the podium. So, first speaker is Matthew Bellamy. He's going to come and talk to us about adherence and factors. Oh no, I'm at the wrong place. Wrong. That was yesterday's talk. Have you found it yet, Adrian?
Naveen Pandita, please. Rocket incision, modified surgical approach for posterior correction of neuromuscular scoliosis case series.
It can only get better from here.
No, Dr. Pandita.
Okay.
You just go home.
I think this is not good. Okay. So, Mustafa Meshneb, are you here? Thank you.
Yes.
Great. Please.
Good morning, everybody. So, Mustafa Meshneb, Queen's Medical Center. Today, my first topic is about surgical complication in neuromuscular scoliosis surgery. We did systematic review and meta-analysis in the last 10 years. As high rates of scoliosis in patients with neuromuscular condition, conservative measurement usually fail to control the scoliosis progression, so still surgical management as a good option. But due to complication rates is high enough, between 24 to 75%, maybe due to concurrent risk factor from this disease and associated comorbidities. So we did this to describe the bold rate of the surgical complication among the studies in the last 10 years and analysis the risk factors within the literature. We did systematic review following the PRISMA guidelines, search strategy in the all medical literature in English published from 2012 to 2020. We included all studies inclusion in neuromuscular scoliosis. We did spinal fusion with at least 2 years follow-up. We excluded early onset scoliosis, less than 30 patients in each study, and also revision surgeries. We started with 336 papers, and we found 23 papers are relevant with a level of evidence between 3 and 4. So we did meta-analysis to detect the bold rates of complication and analysis risk factor within each complication, like preoperative cup angle, intraoperative blood loss, and intraoperation time, pathological diagnosis, and surgical approach, either anterior, posterior, or combined. So we got 2,183 patients in 23 studies. The primary diagnosis was cerebral palsy. Wound-related complication. It's about 13% as a bold rate in 22 studies. And we can see this heterogeneity among the studies, and we found myelomeningocele is the most significant risk factor in comparison to other pathologies and also as a risk factor. Respiratory complication, the second complication, has 11.8 or around 12%. Also, we have only presented in 14 studies, and Duchenne muscle dystrophy and spinal muscle atrophy were significantly higher as a risk factor in comparison to the other studies, other pathologies, sorry. Implant-related complications around 7% in all the studies. In 23 of the study we presented we have the implant-related complication, but with the analysis of the risk factor, nothing significantly different as a risk factor. Pseudoarthrosis, in only 9 studies, are about 5% of incidence as a bold rate and also no risk factor associated. Neurological complication, around 3% in 12 studies presented, and also no risk factor significantly differ across all the studies. Revision surgery. So the revision surgery, about 10% in 15 study. Majority of these revisions we found as about due to wound debridement. In comparison to the last literature published, giving us idea about the relevant or prevalence of complication neuromuscular scoliosis published in 2013, we can compare the result to this paper. We can find this slight improvement in the respiratory complication and also improvement of implant-related complication, maybe due to the usage of the pulmonary protective measurement and increased usage of also pedicle screws. So in conclusion, wound-related complication and respiratory complication remain the most common complication after the scoliosis corrective surgery. Both are significantly associated with myelomeningocele, Duchenne muscular dystrophy, and spinal muscle atrophy, respectively. Thank you.
Okay, thank you very much. I know you've got a second presentation, but they're very different, I think. So can we take any questions, please, on that first paper? Whilst people are coming up to the microphone, I'll ask, was there any information on mortality in these studies?
Yeah, I have some data as regards the mortality rate, but until now I didn't put it in my presentation, yeah. But something I have to put again, yeah, to look again.
Any idea roughly what it is? I mean, I usually quote 2%, but...
So it's not mentioned in most of the study, in the 23, okay? But I think the rate of this mortality is not so high among the studies also.
Okay. Question?
Thank you for that. My question is, you compared to another previous meta-analysis in 2013, how much of an overlap was there of papers that were included in theirs and yours, and how many that you didn't include that was in theirs?
So according to the number of study of this 2013, around the 69 study, and with a larger number of patients, around 500 1,500 patients across the studies. And what the other question, sorry? Sorry, I couldn't hear.
The question being, was there an overlap of papers between the two meta-analyses?
The overall, sorry?
Overlap of papers.
Overlap, yeah. So, yeah, according also the previous study, also they have a large heterogeneity across all the studies also.
Yeah. It's basically how many new studies have there been between 2013 and now? Is that quite a lot of studies?
Yeah, only 20, for my study, 23, okay.
And how many of them were after 2013?
20,
any idea?
No,
okay.
No idea.
Vinay, next question.
Thank you. That was really good. Thank you very much. So two questions. So firstly, the difference you noted in the two meta-analyses, was that significant statistically? And second question is, did you get a sense of anything modifiable? So it's really great to have a systematic review, but is there anything we can do to change and bring down these complication rates? Or did you not pick that up from the papers?
Okay, thank you. As regard, I only show the trend or the difference between the two papers because I couldn't make this statistically significantly test as different number of patients and study. So only to show the trend between the two systematic review. And the modified risk factor, only this 5 risk factor I can get all through the studies that mentioned in all the studies. This is only the modifiable risk factor only. Okay.
Okay, thank you very much.
Thank you.
We'll move on to your second presentation then.
Yes, please.
Is it better to correct the scoliosis first in children with neuromuscular syndrome and coexisting hip displacement and scoliosis?
So, good morning. My second talk will be, it is better to correct scoliosis as a first option in the neuromuscular patient with coexisting hip displacement and scoliosis. So due to higher incidence of hip displacement and spinal deformity in the non-ambulant neuromuscular patient, surgical management some literature give a recommendation as it improves the quality of life and improving of the daily activity for both the deformity, spinal and the hip displacement. But until now, no accepted guidelines. Most of the literature support which deformity to start first. All the studies as expert opinion to do either spine first or hip displacement first. We have one camp or voice that support hip first because they suggest any delay in hip surgery may lead to salvage procedure rather than reconstructive one. Also, the hip surgery give us better release of muscle contractures around the hip and may give better correction of infrapelvic cause of the pelvic obliquity. Also, maybe the pelvic screws used in the spinal construct interfere with the future or the pelvic osteotomy. Spine first, on the other hand, give us better leveling of the pelvis, positive impact on the medical comorbidities, and also delay in this spine surgery may lead to more stiffness and more post-operative risk factors. That's why in our study we aim to compare the incidence of the future surgery in each group and to compare the effect of the first or index surgery on the deformity progression. So we did retrospective comparative study of our neuromuscular patient, non-ambulant. We included young and child and young adolescent patient with Cope angle more than 40, and we used the hip migration index more than 33 and at least 2 years follow-up. And we excluded patient presented with only one deformity. All the demographics, we got 20 patients in each group, 20 patients treated by hip first and 20 treated by spine first. And all the demographics, no significant change as regard the age, diagnosis, and functional level. Preoperative radiological measurement, we can detect there is a significantly higher hip migration in the hip first group and in comparison to higher Cope angle in the spine first group, but pelvic obliquity is no significant change between the two groups. In the hip first, reconstructive hip surgeries done in all patients, mean follow-up around 55 months, and we found at the final follow-up significant progression for the Cope angle and the pelvic obliquity, but all the hip at the end are allocated and no revision surgery for the hip. In spinal fusion done in all the patients with mean follow-up around 40 months with significant improvement for the Cope angle and the pelvic obliquity in this group. Post-operative, the hip state remains stable in 9 patients, and overall hip migration worsening from 49 to 62 significant. Although this hip worsening, only 5 out of 20 patients, they required the hip reconstruction surgery due to pain, and the inverse, 18 patients out of 20 required spinal fusion. We did logistic regression for the hip worsening post-operative, and we found no association between the hip worsening and the effect of intervention in form of pelvic fixation or post-operative Cope angle and post-operative pelvic obliquity. For sure, we have our limitation in this study. That's why we recommend more prospective studies and recommend MDT between the orthopedic team and the spinal team as regard decision making and also discussion with the family and the bigger size and decrease the bias. So conclusion, in wheelchair-bound neuromuscular patient with scoliosis and hip displacement, corrective scoliosis surgery resulted in lower incidence of the need for the secondary hip containment or reconstructive surgery. Thank you.
Any questions for this talk, please come to the microphones. While we're waiting, can I just question, are your two groups comparable? You've got a hip first group and a spine first group, and they seem to be a different set of patients.
Yeah, different set of patients, yeah. But in 20 patients in the hip first and 20 in the spine, Okay, but all the demographic pre-operative are the same, but we have this problem in the radiographic measurement. The hip is higher in this hip group because it is a retrospective, so it depends on the role of the orthopedic. He catches the patient first, so that's why he go to the hip first.
Okay.
So I recommend the prospective, it will be better, yeah.
Alex.
Alex Gibson, Stamel. So, yeah, it's an interesting topic and something I'm quite
Thanks.
keen on. One of your limitations, your slide limitations, was that you didn't talk to your orthopaedic colleagues. So do you not work in the same hospital, or what's going on there? Don't you discuss these complex patients between each other?
Yeah, most of the patients are done in the same hospital, yes.
Yeah. Okay. So I mean, when I talk to my paediatric orthopaedic colleagues, and they usually tell me fix the spine first if it needs doing. Yeah. And if the spine doesn't need doing and the hip does, then you do the hip, and that's the difference. In terms of practical management of these kids, you do what needs doing.
Yeah, that's why we recommend still MDT between the spinal and orthopedic. It will be better idea.
Adam.
Apologies if I missed this, but hip arthroplasty surgeons are getting increasingly interested in spinopelvic parameters. In regards to your cohort of patients who had hip first and then went on to have a spinal fusion, I'm sorry if I missed it. Did any of the patients have a complication with their hip following on from spinal fusion?
For the film,
not at all.
No, not at all.
Thank you.
Okay. No more questions. Thank you very much.
Thank you.
Okay, we're just going to double check. Has Naveen Pandita arrived? No. Okay, so we will move on now to two talks from Martina Tognini. He's going to talk to us about magnetic growing rods.
Or maybe not.
Or maybe not. It's going to be a lot of coffee to drink. Okay, in which case, we will now move on to Matt Bellamy. Sorry to give you palpitations a few minutes ago for coming up a little bit early, but you're going to come up and talk to us about EOS imaging and 3D reconstructions in selective thoracic fusions.
Good morning, ladies and gentlemen. It's a pleasure to be here, and thank you for that opportunity to present my research titled 3D Reconstructions from EOS Imaging to Assess Changes in the Lumbar Spine after Instrumental Scoliosis Correction when we go to T12 or L1. I've got no conflicts of interest. So the picture on the left is probably what many of us are frustratingly seeing in clinical practice, cone down X-ray just showing the thoracic and the lumbar spine with not much else really to see. Now this is due to the radiation levels in these children, and we want to try and reduce this going forward as they will have a lot of radiographic imaging. Now EOS imaging gives us the photo that we see in the middle here. We see the hips, the pelvis, the lumbar, thoracic and cervical spine, and also simultaneous sagittal and coronal images. Now the benefits of EOS imaging that I really want to point out for this talk is that we see a reduction in radiation levels, which means we can get these nice images, but the simultaneous nature of the coronal and sagittal plane means that we can 3D reconstruct the spines. Now, this is a patient that's likely to undergo selective thoracic fusion. Now, as you all know, selective thoracic fusion leaves a mobile lumbar spine. Now, the mobile lumbar spine has often been quite difficult to track and is often reported in the coronal plane. And techniques of reporting it in the sagittal and also transverse plane have often been time-consuming and difficult and often unreliable. So we took our surgical waiting lists from the date that we introduced EOS imaging, and we wanted to look at to the present day. We wanted to make sure our patients had a preoperative, a postoperative, and at least a 1-year EOS scan. And this gave us 20 patients who had all 3 time points, and then we could model their lumbar spine. It is also worth noting that we had to exclude 55 patients, even if they had EOS images, because the radiographic coning or radiographic pictures were not good enough to recreate. So what does EOS tell us about our corrections? Well, we're getting a 50% correction in the thoracic spine, and we're getting about half of this in the lumbar spine. We're not changing the sagittal balance much, and we're actually getting quite a nice derotation of the pelvis, about 40 degrees. Now, The point of this talk and what I really want to point out is that apical vertebral rotation is not changing much in our lumbar spine after selective thoracic fusion. Now, EOS has many advantages for us in Sheffield, and it can really be utilised to look at the transverse plane, something that hasn't really been done before in normal radiographic images. This can be done through looking at the bird's eye view of the spine of the model. We can see the SRS Da Vinci view here giving us an average lumbar rotation. And more importantly, what we use most often is the bar charts giving us rotation at each vertebral level. And it is worth noting here that EOS has the added advantage of neutralising the pelvis before it gives you the rotations to cancel out how the patient is standing or any radiographic challenges. We further broke down our patients into Lenke classifications. And in our 1A patients, what we found is so a nice 60% COB correction, and we were changing the apical vertebral rotation by about 40%. In the 1B patients, however, our COB correction was about half of this, and we were actually not changing the rotation in the lumbar spine at all. And in the 1C and 3 patients, we were getting even less COB correction, and actually we were transmitting that rotation from the correction down into the lumbar spine and making the rotation worse. Now, does it matter what correction style we do? Well, if we do a concave construct, we're changing the apical vertebral rotation and also the average lumbar curve by about 20 degrees each. However, if we use a convex construct, although the lumbar spine on average is rotating, it's rotating less, and actually we're not changing the apical vertebral rotation of the lumbar spine. Now, in 2020, Shen and his colleagues in Montreal released this paper thinking about AAS in a new 3D classification. Now, he proposed 11 different classifications based on AI algorithms, and we wanted to see how these compare to our patients. And what this rather complex and hard to read table shows is that many of our patients with Lenke classifications slotted into many of the Shen classifications, suggesting that the coronal classifications of Lenke are missing some of those 3D parameters. So what do we need going forward? Well, we'd really like to have more EOS imaging of patients with selective thoracic fusions from multiple study centres so that we can make more generalisable results. We also don't know whether these change in rotation actually makes a difference going into the future. Does this mean that they have worse spinopelvic parameters? And does this mean that the length of the construct will change eventually? So what are the key points I think are worth mentioning, and I hope you take home from this talk, is that global spinal alignment is really important. And in Sheffield, we've reconsidered our radiographic protocols to monitor these patients in a 3D format, both preoperatively and postoperatively. I also feel like we're missing part of the picture by reporting the lumbar spine correction as coronal, in only the coronal plane. And 3D classifications, both preoperatively and postoperatively, highlighting this transverse plane, could predict patients that are really going to do well from selective thoracic fusions and those which aren't. Thank you very much for listening. I'm happy to take any questions, and my contact details are there for anyone who wants to get in contact with me.
Okay, so any questions for this paper, please come to the microphone. Whilst that's happening, on a practical note,
yeah.
Is the modelling of the lumbar spine from EOS images automated? And if it's not, who does it and how long does it take?
It's not automated. I do it, and it takes a long time. The lumbar spine itself is actually intrinsically quite easy to model on EOS because the anatomy is often clearer than in the thoracic spine, where you have the lungs, some of the digestive tracts, and depending on what the patient has ate and the level of inhalation while the EOS is being taken, it can take probably up to an hour to model the whole spine. Modelling just the lumbar spine probably takes between 20 minutes and 30 minutes.
And is there any potential for using EOS imaging to model shape of the ribcage and get a three-dimensional thoracic cage shape?
You mean model the ribs as well?
Yeah.
Not as far as I'm aware, no. At the moment, EOS is limited from T1 down to L5 and the sacral plate.
Yeah, there is some experimental software at the moment looking at rib modelling. You'd have to speak to EOS about that.
Hi.
Hi.
Yeah.
No, he's going to. Okay. Sorry.
Julian Jones from Samuel. Thanks for your talk. It's really interesting. I just want to know the EOS rotation is actually inferred rather than actually calculated, isn't it? Because it's an APN lateral view.
Yeah.
And they just do a kind of population modeling type thing to infer the rotation.
So unlike a CT scan, EOS modelling gives you the ability to calculate rotation based off anatomical landmarks. So it has more subjectiveness to, say, a CT scan. But due to the ability of EOS to give you an anatomical 3D shape of the vertebra and match that to the anatomical landmarks, it's more accurate than the traditional radiographic measurements seen from X-ray.
You've got 25 minutes of questions we've got to fill, folks.
Yeah.
So, is there anything else you want to ask?
Yeah.
Please come to the microphone.
I'll just ask a question of the audience, really. So I can see many of you work in different paediatric spinal deformity units. Who's got an EOS machine? Yeah. Okay. And who would want one if they could get one? Right. Okay. Yeah. And it's those nice guidelines from a few years ago that are causing the trouble, isn't it?
What guidelines were they?
So
guidelines causing trouble? I've never heard of
this.
Well,
yeah, okay. Yeah. Thanks, Alex. Have you got a question?
No, I've got a question. You made us allusion to doing concave rod correction or convex rod rotation correction first. I presume that means which rod you put in first. So just a question about your technique and why you chose one over the other. What influences the way you do it? Is it just you as a single surgeon, or is
this is the whole unit, and we're pretty much split as a unit. So half the surgeons are concave correctors if we're doing a thoracic curve, and the other half are convex correctors. Just philosophy, really.
And I suppose the other question about implants, then, you've got your thoracic correction was 100% implant density. Does it matter? And does that make the modelling easier or harder? Do you get a different amount depending on how much?
So the reason we didn't model the thoracic spine with EOS is once you put the implants in and the rods, it becomes very difficult to see the anatomy of the thoracic spine. And as we alluded to, it's not a CT scan, so you have to map the bony anatomy. So I think the lower the implant density, the easier it is to identify and model the spine. But we haven't done any work into the thoracic spine yet. Hi, yeah.
So I got another question about, you mentioned also about the pelvic rotation, which you measure pre and post-op on the radiographs. And this is something I struggle to understand, because some of the radiographs you see, and the chest is perfectly AP, and the pelvis is completely skew. This is on our standing traditional radiographs. And then, of course, you look at the supine bending views, which we do, and the pelvis is usually perfectly square, and the chest can be wherever. And what are you actually measuring when you say you've got a 40% improvement or change in the pelvic rotation? And how do you know it's not just the way the patient was standing? Is it a 40% difference to the rotation of the lumbar spine or the thoracic spine, or what is that actually saying?
Could I have my slides back on? It makes it easier to explain this. But one of the benefits of EOS and why we had to exclude so many patients from our analysis was that we really need the acetabulum and the femoral heads in the image to gauge. So if the bottom image there, you can see the femoral heads and the acetabulum. And when you're starting to do the modelling, you select these as reference points on both the AP and the lateral view. And when EOS calculates the rotation in terms of its bar charts at the top, it gives you that from a neutralized plane. So it calculates what the rotation of the pelvis is in the image and takes that off or on to your rotations. And that gives you not only rotations for the lumbar spine, but it gives you the whole acetabular relationship between each other, which is what we're reporting there in terms of pelvic rotation, is really how rotated the two acetabula are to each other.
But you've made no change in your surgery's made no change to that. You haven't done a pelvic osteotomy, have you?
No, we haven't done pelvic osteotomies here, no.
So
But I guess what the pelvic rotation is probably trying to say there is the way that the pelvis sits and the patient stands in the position from the preoperative to the postoperative.
Yeah, exactly.
It's not an anatomical change.
Correct. Yeah. Okay. So one other comment, because no one else is coming to the microphone. The first X-rays, the X-ray collection that you had on your slide, where you said you didn't like the standard X-rays you were getting, the one on the left side.
Yeah.
So that is not an acceptable X-ray for a spinal deformity patient.
But it's often what we see.
Yeah, but I think if it's done in your unit, you've got to send it back and say, do it again, to include T1 and the pelvis. Yeah, I mean, if it's done in another unit, that's fine, but it's not. But if that's not an acceptable X-ray for any unit doing spinal deformity, in my humble opinion.
I agree completely.
I think we're done.
Okay, thank you very much.
Thank you.
And so the last talk of this session, Libby Gouda, please.
Hello, good morning everybody. My name's Libby. I am a medical student from St George's in London, and today I will be comparing the use of 3D printed custom navigation jigs to freehand pedicle screw insertion in posterior spinal fusion. So first, I'll just speak a bit about what 3D printed jigs are. So this technique utilises innovative 3D printing technology to create two products. So we get a 3D printed model of the spine and custom navigation jigs, which are modelled from a 1mm axial cut CT scan. So the 3D model of the spine in itself is a really useful visual aid, and it allows the surgical team to visualise the curvature and the screw trajectory, which you can see from the pedicle markers in the image on the right. So what is the need for these jigs? Freehand pedicle screw insertion has inherent inaccuracies, and therefore the surgical team will quite often utilise navigational techniques such as intraoperative CT, fluoroscopy and robotics. However, these can significantly increase the intraoperative time and the time for which the spine is exposed and vulnerable to infection. What's nice about 3D PCNJ is it doesn't disrupt the workflow, and it may even enhance it, as we can pre-plan which screws we can use, and these can be prepared in advance by the surgical team. The surgical team is also exposed to less radiation, as there's less need for intraoperative CT. We can also create really useful preoperative plans from this, which can alert the team of any unusual anatomy of the vertebrae, and again, suggest the screws that we should use based off the anatomy of the pedicle and the dimensions of the pedicle. On the left, you can see a picture of the jig fitting onto the 3D spine, and on the right, you can see it fitting onto the T3 vertebrae. These jigs are vertebra-specific, and they are secured onto the vertebra with two guide pins, and the channels through which these guide pins are inserted are also customised so that the guide pins sit within the cortex of the bone. So in order to make our comparison, we started with 50 patients in each group that were matched by demographics and Lenke classification. We then decided to only include adolescent idiopathic scoliosis cases, leaving 43 patients in each group. So we retrospectively collected data on the following parameters, and also specifically collected data on time for screw insertion and blood loss during screw insertion for our 3D PCNJ group. Just another note, the time and blood loss for screw insertion does include the facetectomies for our 3D PCNJ group, and this is due to the surgical technique that we use. So when we use the 3D PCNJ, we start from the cephalad and work caudally, and the facetectomies are carried out after each level. This is because the facet joints have to be left in for the jig to fit on correctly to the vertebra. This is slightly different to how we do the freehand technique. We usually do all the facetectomies at the beginning, start from the bottom and work upwards. So initially we found no differences in duration of surgery and blood loss. However, we did find that there's a significantly increased number of screws in the 3D PCNJ group. So we decided to take a closer look at this. It was found that the screw density in the 3D PCNJ group was significantly higher, which we believe will create a more stable screw construct and potentially provide a better coronal correction. Unfortunately, there was no data available for time for screw insertion in the freehand group, so we opted to take a relative per screw time by dividing the total duration of surgery by the number of screws. And from this, we found that per screw, 3D PCNJ is much faster. As expected, patient-reported outcomes improved in line with freehand, as did radiographic measurements. In our freehand group, there were 2 instances of spinal cord monitoring events, which both occurred during pedicle screw insertion, and these were both reversible. And there were none of such events in the 3D PCNJ group. 3 patients in the freehand group had to return to surgery, 2 due to spinal cord monitoring events in the first attempt and 1 due to a loose implant, whereas only 1 patient returned to surgery in the 3D PCNJ group due to a loose implant. So finally, I'll just leave you with some take-home points. We have shown that the use of 3D PCNJ is safe and efficient. Patient-reported outcomes improve in line with freehand. The use of 3D PCNJ allows for high-density screw constructs, which may help mitigate screw pull-out and provide a better coronal correction. And 3D PCNJ allows for more efficient screw insertion. Thank you.
Okay. Thank you. Any questions whilst Julian's getting to the microphone? To make these jigs, do the patients all need a CT scan before surgery?
Yeah, they all have a preoperative CT scan, yeah.
Okay. Julian?
It's the same question. Is that the whole spine 1 mil thick cut?
Yeah, full spine.
I mean, it'd be nice to know how much radiation these kids are exposed to.
I wouldn't be totally sure on the exact amount of radiation that they're exposed to, but I think when you're comparing it to the use of other navigational techniques, such as intraoperative CT, it probably balances out, but I don't have the exact data to give you there.
Many years ago, there was a study looking at whereabouts the correction occurred in scoliosis surgery in adolescent idiopathics, and quite a lot of the correction occurs with general anaesthesia and prone positioning. And was there any mismatch between your jigs, your CT scan jigs, and the patient having been anaesthetised, the muscles stripped off, and obviously that not being the case on your pre-op CT scan?
I think sometimes there are jigs that don't fit quite correctly, but we have, when we're in theatre, we have the 3D model of the spine as well, so we can check that it fits correctly onto that and then onto the patient. And yeah, sometimes it doesn't have a great fit, and then you can either just do that level freehand or skip the level.
Okay. Vinay?
Okay, thank you. Apologies if I missed it completely, but I understood that the benefit you probably got was that you didn't get the cord events on one side as compared to the other, correct? So the cord events that happened, were they because of pedicle screw breaches? Or
yes, spinal cord monitoring events that occurred during pedicle screw insertion.
And
yes.
Did you actually, and again, forgive me if you did put it up, did you actually have a comparison of accuracy for one compared to the other? So did you do anything to look at radiological accuracy, for example?
No, I don't believe we had any data for that, unfortunately, but that would be very interesting to look at in the future if we can find that data. Yeah.
Thank you. Thanks, Vinay. Alex?
Yeah, we've tried a little bit of 3D jigs in the lab, but I've never been brave enough to use them in real life. So my concern is this, in my mind, there's quite a difference between putting a drill down a pedicle in a deformed spine when you've got 3D navigation and you're reasonably confident, and accepting the pre-op CT scan is not going to be any different. I mean, I don't think it will be much different in the positioning because it's the shape of the bone. You don't change the shape of the bone. It's just the relationship of the bones you change when you position. So, but I have some concern about doing a fine slice CT for the pre-op scan. But there is some work on what they call sort of black bone MRI, and ultimately I think that's going to be the way forward to do a preoperative plan. You can make almost a synthetic CT scan from an MRI image, Have you had any experience with that, or?
No, I don't believe we've been using that at St George's, but I agree it's probably the way forward.
Marcus?
Hi, thanks for an excellent and interesting talk. Two questions. One, to reiterate the point that Vinay was making. You didn't do an intraoperative O-arm spin on either group to check position and then alter screw placement, because we know that freehand technique or even navigation, you can get deflection of a screw and therefore you can change it intraoperatively. So you haven't described any of that. And two, could you tell us how much each jig is per level, please?
How much as in how much it costs?
Yes.
So I don't know the exact cost. I'm only a student, so I'm not present in the theatres very much.
I do apologise.
And I don't know much about the costs.
For your senior author.
But what I do know from my supervisor is that these jigs can be registered as patient bespoke implants, so they're covered by NHS England, which helps with the cost. Obviously, it does come with quite a cost, as does any navigational technique, and I think it's just down to preference what surgeons prefer to use, be that the O-arm or the jigs or robotics, whatever they prefer.
Thank you very much.
Thank you.
Okay, Rav?
Very well presented. My question was, you tried to get the two groups to have similar curve types and try to control for that.
Yeah.
But why was there such a big difference in implant density? Was that intended and planned?
Yeah.
And why weren't they similar?
So I've asked my supervisors this myself because I'm not entirely sure, and I'm not sure whether they're entirely sure either. I'm wondering whether it's because you can put the screws in much faster and then they feel like they've got more time to place more screws and have a more stable screw construct, or whether it's an aspect of safety and they feel more confident to place screws in, more tricky pedicles. I'm not entirely sure, but I would love to find out from them as well.
I think it's just psychology. You've got a jig, and you can put a screw in, so you're going to do it. It's too easy not to do it.
Yeah.
I certainly see that in some of the navigated cases we do, because we all know actually that if you put super high density screws in, actually you sacrifice some of the coronal correction. So it's not that you get a better correction; you get a slightly different correction.
Okay.
Okay, thank you. Just before everybody goes for coffee, I'm assuming that everybody wants to come to BritSpine in a couple of years' time, which means that we need the industry to support us in BritSpine in a couple of years' time, which means that will you please go around the stands during the coffee time? I know we've not seen each other for so many years, but we do need to support the industry, please. So if you could just spend a bit of time going around the stands, that would be much appreciated. Thank you.